Good morning, everybody. Being from Bhiwani, this auditorium is nothing new to me, but really a place of learning for me too, for over the last 35 years. I am grateful to the chairpersons and the Ganga Ram team to give me an opportunity and invite for this one-day CME. I go with my first slide, which is about the topic anatomy of anal sphincters and its significance. If we understand that the pelvic floor muscles are arranged in the form of two cylinders, one within the other. The inner cylinder is the termination of the gut, and the circular muscles, they make the internal sphincter, and the outer cylinder consists of external sphincter and the puborectalis, and the upper part forms the, this is the funnel, upper part forms this funnel, these are the levator ani, and the parent tube gets twisted, and this anteriorly this blue color tube is basically the genitourinary system which develops from the parent tube. Yes. Little bit embryology in one slide only to understand how come the glands of a mucosa come to the muscles in between, and that happens not at very many places, only at 3-4 places in the body, wherever there is a parent tube which gives rise to a daughter tube, like in esophagus, at duodenum, and at the cloaca. How it works? So this is the endoderm which develops, and this is the ectoderm. This is the endoderm, gives the columnar mucosa. This is the ectoderm, the pit, and the mesoderm is the internal sphincter develops. Then the lower part becomes thick from the circular muscles, and in the meantime, the external sphincter also develops. But the muscularis mucosa and the longitudinal muscle doesn't come between. Before that, the gland comes. That's why the gland goes in between. And these are levator, they get inserted there, and this is how. That is the reason that you find that these glands, which are actually the mucosal glands, but they come to lie between the muscles here. That is the reason, and that gives some answers to it, that how come the intersphincteric space have these glands and infections. Actually, these are the mucosal glands. It's like deep glands, Brunner's glands, other glands in the body, it's like that. If you see the anatomy of the perineal muscles and sphincters for the mechanism of the continence, the lateral compression is by the pubococcygeus muscle, as you can see here, and the circumferential closure is by the external and the internal sphincters. Angulation is by the puborectalis, and one by one we will study the little anatomy of these sphincters. The internal sphincter represents the distal 2 to 0.4 centimeter condensation of the circular muscles of the rectum. It contains both the intrinsic myogenic properties they have seen in putting in a bath without neurogenic or endocrinological stimulus, still it remains contracted, and extrinsic autonomic neurogenic properties are there. So nerve supply is by the superior and the inferior hypogastric plexus. The autonomic nerves, they supply this muscle, and how it acts we'll talk about. Internal sphincter, it stops little short of here the external sphincter which comes downward, and there is in between there is a small groove. And clinically, to appreciate this groove, the intersphincteric groove is very important, because this is the line of embryonic fusion. Okay, and here we will be doing a lot of surgery through this embryonic fusion plate. That's why it's very important to understand. And nowadays with the anal ultrasound and MRI, we should also understand the anatomy of this on endo-US. Another muscle in between the two is the conjoint longitudinal muscle, which is actually the outer longitudinal layer of the rectum. The fibers of the levator ani, they contribute towards that, and it is called as, when it comes to the skin, it comes called as corrugator cutis ani. It has 4 branches sort of thing, like this is the circular muscle coming down with the conjoint longitudinal. Part of it goes to the submucosa, and here it joins the muscularis mucosae. That's why it's called as, these are the treats ligaments which support the submucosal cushions. Other fibers come down in between the two, that is called as intramuscular septum. Few of the fibers, they go up to the skin through the external sphincter, which is the subcutaneous part, and few of the fibers, they go towards the ischiatal fossa. Even few fibers goes to the deeper part of the external sphincter. and a slip of it goes to the urethra, cardus erecto-urethralis, and the component goes to the anococcygeal ligament, because they have studied that in the anococcygeal ligament, you don't have only skeletal muscles, you have some smooth muscle component also. That's why it is called as a skeletal of the anal canal. External sphincter is an elliptical cylinder of striated muscles and covers the entire length and slightly distal to the internal sphincter. And if we see the parts, classically we divide these parts into the subcutaneous part, which is just below this part, and the other part is the superficial part, deeper part closest to the puboretralis, and then puboretralis and the other levator muscles. But actually on surgery, we don't find all these things. We have a clean one sheet of the muscle, most likely to be one muscle unit attached by the anococcygeal ligament posteriorly and pubic bone through the perineal body. It's not attached to the perineal body. It's actually attached to the pubic bone. This is no different from any other muscle, where one muscle is attached to the one end of the bone, and the other end is attached to the other end bone. You can just do exercise your own. Whenever we do Kegel exercise, we ask the muscle to contract. You can feel that your coccyx moves anteriorly. That's why the moving part is towards the coccyx. Nerve supply is dual nerve supply. You have supply from the pudendal nerve, S2-3, and from the perineal branch of the muscle, there's S4, and there is an important thing, there is a bilateral overlap. Suppose this is the anal canal, and the nerve supply from this side will go to the other side also, and from the other side will go to this side also. That's the reason that when we were doing a lot of sweeping to clean the ischiorectal fossa, and still we don't have any patient saying that I have some problem with the external sphincter. The reason was dual supply from both the sides, and that was the reason that we could escape. Otherwise, there will be some problem. Anatomy, if you see, the most commonly accepted model is on your left side. On your right side is the Shafiq's model, who says that it's a 3-loop system of the pubis, coccyx, and but nowadays we understand, and Goliger also said that it's a one sheet of muscle. We cannot actually differentiate on operation table, but yes, the functions are little different. On clinical examination, you can find out the upper end of the external sphincter, where it makes the puborectalis sling or the anorectal ring here. As soon as you put a finger inside, and when there is an empty space called the rectal ampulla, this is the anorectal ring, and you can have on sonography, you can see that this is absent in this case, telling you that is all external sphincter, and anteriorly there is obstetric injury. Something special about external sphincter. External sphincter and puborectalis, they maintain unconscious electrical tone through a reflex arc at the caudagon region. It has both the fibers, the slow twitching fibers as well as fast twitching fibers. That's why the slow twitching fibers, they help in tonic contraction, and the fast twitching fibers, when there is a sudden rise in abdominal pressure, that helps to control the feces. It can maintain voluntary squeeze only for 30 to 60 seconds, and there is an asymmetry. If you see anteriorly, there is an asymmetry in a female. This part is absent. Puborectalis also doesn't have any end here because it is attached to the pubic bone, and this is very, very important. Even in nulliparous, 76%, people, they may over-report that there is an injury to this muscle. Actually, this is a normal anatomical deficiency anteriorly, and that's why there is some reason that we don't advocate, in anterior case, we don't advocate a fistulectomy in a female. But the recent studies by 3D transanal sound, now we find out that this perineal body is actually, it's a choraha hai. Perineal body is a crossing. It doesn't attach over there, and from posterior it is coccyx, anteriorly through the perineal body has transverse perineae, or as bulbospongiosis, this muscle is attached to the pubic bone. So this muscle is no different from any other muscle. Muscle has only to contract or to relax. It is the fascicles within the muscle which decide what type of action it is going to take. For your elbow, this is the action. For your digastric belly, you have a superior belly, inferior belly, and in between you have a loop. So that fascicle arrangement actually changes the action of the muscle. Here also, it is a figure of 8 configuration of the external sphincter actually, and it doesn't have a donut-like effect. It has a bursting type of effect, and that's why very important. What we think episiotomy is a muscle sparing, it's not. Episiotomy, you cut bulbospongiosis, you cover, and you also cut the transverse perineae. That's why if you repair just by a overlap, it will not be a proper repair. And this is the slide I will tell you the bursting effect. And you can have just a click of this picture, though a busy one, showing you the different characteristics of the muscle. Only one thing I would like to mention, that the resting anal pressure is, if you take the muscles only, the resting anal pressure 70% is by the internal sphincter and 30% is by the external sphincter. That is for the muscle part only. And how it is there, the resting anal pressure is so much? Because the source of calcium required for the contraction in a case of internal sphincter is intracellular. The nature is so beautifully made the things. Intracellular calcium immediately gives to contraction and there is a tonic contraction. And fast and slow twitch fibers in the external sphincter does the dual function, function of tonic contraction as well as a sudden control whenever there is a sudden rise in intra-abdominal pressure. And like smooth muscle conjoint also has this. This is, you can see the anatomy on the MRI, day in and day out, you see that. And clinical application, what is the significance? Because of the attachment of the external sphincter, the anal opening is not a round thing, it is a slit. So whenever you put a speculum inside, always put in the anterior-posterior direction, and then after the lubrication, you can just give your direction to your speculum. Otherwise, you will increase the mucosal injuries, abrasions, pain to the patient, especially if done without anesthesia during examination. And these anal sphincters, they are arranged in a way that they create certain potential and real spaces. I will not dwell on them because the next lecture is on perianal spaces. And this slide is very important because anal sphincters are actually for the continence mechanism. Because of anal resting pressure, we have discussed 70 and 30%, anal squeeze pressure by the external sphincter, and how much division of muscle we can do, we will decide. Classifications are all based on the extent of the division of the external sphincter. Anorectal ring is very important, which makes the pubertalis along with that. And another important factor, all these muscles, they degenerate with age. In this slide, you see 70%, 30% in a young patient. As soon as we start aging, 10% is lost from the internal sphincter, 15% is from the external sphincter. And in an elderly patient more than 60, if you cut only the internal sphincter due to sphincterotomy, only left continence is 45%. So now you just can imagine that when there is a birth injury, but incontinence happens late in a female, reason is degeneration over the time and it goes beyond the threshold. That's why we nowadays suggest that even if you do a fistulotomy, kindly repair the muscles. Anatomy of sphincter is very important, that how much external sphincter can be cut without jeopardizing fecal continence. Even if there is no previous risk factor for fecal incontinence like capacity and the compliance of the rectum previous surgery, we broadly say that 30% of the external sphincter you can cut. If you cut around 50%, always repair, never cut anorectal ring, and there are controversies around it, and we will dwell on them in coming lectures. All the clinical evidence, because of the attached muscles arrangement, roadmap of some predictable routes taken by fistula and around the anal sphincter as suggested by Parks. You can see intersphincteric, transsphincteric, extrasphincteric, suprasphincteric. And what is the sphincter basis for the anal sepsis drainage? If any, there is a watershed barrier. If anything is within the skeletal muscle, you will drain inside. If anything is outside the skeletal muscle, you will drain outside, and this still holds good. And similarly for the fistula, nowadays what we propose is that for fistula you may learn any amount of classification, but try to find out when after your clinical examination and your radiological support, try to find out the components of the fistula medial to the external sphincter, component of the fistula through the external sphincter, component of the fistula outside the external sphincter. Treat them separately, inside, outside, and through the muscle. Don't cut the muscle too much. And if there is a well-formed track, do excision. If there is not a well-formed track, do drainage. Internal sphincter, we all understand, to modulate the anal resting pressure in refractory cases of anal fissure. Partial lateral intersphincterotomy is done here. The surgeon, when he lifted these muscle fibers, you can see that few fibers are of the subcutaneous external sphincter, these red fibers, and these white fibers are of the internal sphincter. To my associates and to my students who come, I tell them that internal sphincter looks like chicken and external sphincter looks like mutton. So excessive dilatation, division can lead to passive swelling. Another significance of this embryological fusion is that you can have a TME plane in between the intersphincteric groove, and you can spare the external sphincter. You can do the external sphincter sparing surgery even in low case of rectum. You can do a reverse TAMIS also or TAMS also, and this is how this plane is so important. Sphincter not only this incontinence, constipation. If this is a normal mechanism, and this is a normal mechanism of defecation, that the synergistic contraction of the abdominal muscle and relaxation of the pelvic floor muscles, it leads to normal, and your hip flexion will further obtuse this angle and rectal angle and helps in defecation. But when there is a dyssynergia between these two type of muscles, there will be a pelvic outlet obstruction and constipation. Hirschsprung disease, though there are no myenteric neurons in the internal sphincter itself. However, it is richly innervated by the processes of the myenteric neurons located in the rectum, and degeneration of these myenteric neurons results in impaired internal sphincter relaxation, and this is a hallmark of Hirschsprung disease. And pathognomic finding on manometry, RAR is absent in the Hirschsprung disease. So this is all about the anatomy and the functional significance of these muscles, and it's all about the fistula surgery also. You should understand how much to cut, how much not to cut. We'll be just dwelling in the further lectures. Thank you so much, and if there are any questions, I will love to answer. And I'm really grateful to increase my knowledge of anatomy and physiology of sphincters giving me this lecture. Thank you so much.